Hello everyone, welcome back to my channel. My name is Melisa Rodriguez. I am a fourth year medical student in Florida and I make videos about my medical school experience, any advice, clinical skills. So if you're interested in this kind of content, please make sure to subscribe to my channel for more of these kind of videos. This video specifically is about how to present a patient in an efficient way to an attending in specifically the internal medicine service and all the subspecialties within internal medicine. All of these presentations that are different from surgical rotations. I made a whole video about how to present in surgery rounds and I will link it up in this video. So if you're about to start your surgery rotation, you will look into that one. I struggled so much with the presentation during my third year, and we're taught just the SOAP form, but when it comes to the real world, you want to know the different types. There's different type of presentations, there are different things to consider. So I thought, oh, I can make a guideline of my thought process right now that I've learned and gone through mistakes and practicing, so that you guys can have a framework on how to approach these presentations during rounds. This is the main way that an attending gets to evaluate you during third year rotations. It's true that with internal medicine presentations, we want more details, right? Because we're managing the patient as a whole, holistically. So yes, we want more details, but that doesn't mean we want a very long presentation or one that is all over the place, or one that a student freaks out in the middle of it because they don't know exactly what to continue saying. So it's true that you learn by practice, right? You get better at things like remembering details and not having to write much in a paper when you're going to see the patient, but for me this was the most difficult, because I felt like I was really good at bedside, getting the story from the patient, right? Making a connection with the patient. But then when I went to transfer this information into oral presentation in less than 10 minutes, because you have to do rounds and sometimes for like a lot of patients, it becomes a little tricky. But if you follow this guideline that I'm gonna give you, I think it will make it more smooth and you know what you need. Starting your morning, it's gonna be more efficient and everything because you will have a framework. Let's start the video. I know this has been a long intro, but let's start. So first of all, IM service has different type of presentations. There's the H&P or history and physical presentation, which is a presentation that is the longer one, right? The one that the attending knows nothing about the patient. It's a new admission and you're going to see the patient for the first time and you need to get everything, right? All of the information. And then there's the progress note, in which the attending already knows about the patient and you will mainly give updates and overnight events as a subjective part. The subjective part is the one that changes, okay? Now, when a new attending comes into the team, which happens frequently because the hospital is, switch with each other every 7 days in most hospitals, the new attending comes, but this is a patient that has been hospitalized for a long time. You do need to give a little bit of a hospital course and a little bit of a summary and a little bit of background on that patient, so it becomes a little longer again. So those are things to consider that I didn't think about before. I thought everything was like SOAP, just follow SOAP, but no, there's specific things to say and things to include in every presentation, depending on the listener as well. It's true that each attending wants you to present things slightly different, but this is a generalized framework of what most people think will be a good presentation, okay? Based on my experience, of course. I have gone through multiple fails and I feel like now during my fourth year, I'm doing my audition rotation now, I'm feeling much more comfortable presenting patients by following these methods, okay? So first, let's start. I'm gonna be looking at my computer because I wrote the guideline here. Okay, H&P presentations. This is one of the most important presentations. The first time the attending is hearing about the patient, and it's gonna be a little detailed, okay? The first thing you give is a one-liner. One-liners are the most important, relevant information. Could include subjective, objective information, both, okay? Because you don't want to save critical objective information for the end like after you said all your subjective, that is beginner level. That's what I realized while I was rotating, that in the one-liner you give important information that the doctor needs to know right away. First you give, of course, what's the last name of the patient, age, sex, right? Then you're gonna give the 3 or 4 most important past medical history points, or history, because sometimes saying past medical history means that it happens in the past or that it has resolved. No, you want to say history of blah blah blah, right? Like 3 or 4 that are the most important to mention. Of course, if the patient only has one, just say one. But if a patient that has like 8 or 9 comorbidities or medical conditions, you only want to say the most important as the part of the one-liner, because you're gonna go through the rest of the past medical history later, okay? As in the one-liner, the first thing that you say 3 things, okay? And then you say 3 points of HPI. What is the chief complaint? And any important characteristics or associated symptoms that are really, really important to the chief complaint, okay? Then 3 points of relevant data. You can choose from the physical exam. If something comes out like really relevant, really significant, say it in the beginning. Like in the physical exam, something really important, labs abnormalities that, you know, jump out, imaging abnormalities. Let's say they found a mass in the stomach, in the CT, abdomen, pelvis. You say that, okay? This is your one-liner. The one-liner can also include things from the ED course, like physical exam, labs, and imaging, if it's relevant, okay? So you can kind of like obtain things from the ED course and put it in the one-liner. So, for example, this is a 57-year-old male with past medical history of hypertension, CAD, atrial fibrillation on Eliquis, that presents with chest pain, started yesterday, it's substernal, it's radiating to the left arm, troponins have been to this number, and EKG shows ST elevations in the leads V1 to V3, for example, okay? This will be an example because it includes all the most relevant information that the doctor needs to know right away. One-liner, first thing, right? First thing, okay. Then we go into the ED course. The ED course is part of the admission H&P, right? This is a new patient. What has been happening in the ED before we admitted them? The ED physician does a lot of work up too, right, before we get them, and then they decide to admit them, but you need to know what has been done already, right? So ED course, in the ED, the patient presented with these vitals, these lab abnormalities, this imaging, their further workup. For example, if they did a UA, if they did any urine drug screen, if they already did any procedures, you should mention it. And then what did they receive in the ED already? What IV fluids did they receive? Did they receive a 1 liter bolus already? Which medications have they received? Any analgesics, any respiratory treatments, any oxygen supplementation? This is the main things that are happening in the ED as acute management, right? Then after that, the doctor already has a picture of what's been happening, what the pertinent positives, pertinent negatives have been from the initial workup of the ED. Now you're going into subjective. You see how it's not only soap at the beginning of it needs to be succinct and needs to include some objective information as well, the beginning, before you go into the actual subjective, okay? This is the actual subjective, HPI. HPI, you're gonna say again the chief complaint and say the HPI in a chronological form. It's a story. This includes if the patient had a recent hospitalization for similar symptoms, when, what happened, how did they manage the condition during that hospitalization. You include if there's any recent hospitalization or if there have been multiple hospitalizations for the same condition. Then you present the story. HPI, if it's pain, of course, OPQRS, TA, I don't know if you were taught that, but that's like onset, place, or location, quality of the pain, radiation, severity 1 to 10, T, timing, is it constant or is it intermittent, does it go and come back, and associated symptoms, okay? That is part of the HPI. You want to say it in a chronological order from the patient's perspective. Think about it as if you were the patient telling the story. Because if you say things that happened today, oh no, but then 1 year ago this happened, then it's gonna, confuse the listener. The listener expects a story. This is the chief complaint that they've been having for one day, right? But then you go back 4 months, she had this surgery for, right? If it's relevant to the chief complaint, of course. 3 months ago, she started feeling this. She was recently hospitalized 1 month ago for similar symptoms. They treated her with this, was discharged on these medications. 2 days ago, she developed this and this and this. And 1 day ago, she developed fever and felt her heart racing, and that what made them come to the hospital. At the end of that chronological story, you want to say what actually made them come to the hospital today instead of, when the symptoms started. If they started today, of course, you don't have to say that. But if they started 2 weeks ago, what made them come specifically today? Okay, that is the HPI. That is really important. That's the story of what's going on. What made them come to the hospital, okay? Then you go into past medical history. Include, their medical conditions, if they have any psychiatric history, medications, allergies, really important, okay? Of course, the medication, you want the doses, you want the frequency, all of that really well. You do a good medication reconciliation. Some hospitals will have pharmacists that do this, but if you're the student and you're the one, responsible for the admission, you want to do your med rec as well, okay? You want to know what this patient was taking, if they weren't taking their medication, which one did they take, did they not take as prescribed, you want to know that, okay? Past surgical history, really important. Family history, social history, of course. All of these things are part of the H&P. Then you go into how are they feeling now, okay? Because you gave the ED course how they presented, right? But we want to hear how they were feeling when you visited them. So how is the patient feeling now after the medications in the ED? Is the pain control? Is the nausea control? What are the consultants that are following? Because the ED have already consulted other people. Do we already have other consultants on board? For example, neuro usually gets on board pretty quickly if it's like syncope or seizure or stroke. Then what did they say? If they say something in their notes, just mention it, okay? So that is an H&P, okay? The subjective part of the H&P. This is what differs from a progress note. The rest is the same. I'm gonna continue through the rest, and then we're gonna go over by the last part of the video on how the progress note is different, okay? But after the subjective information of the H&P, you say the objective, of course. Start always with vitals. Some physicians like the specific numbers. Some of them just want, whatever's abnormal. But if you're giving a presentation for the first time, say the specific numbers and say the ranges. Blood pressure, systolic ranging from this to this, diastolic ranging from this to this, okay? And same with the heart rate, respiratory rate, oxygen saturation, okay? Physical exam goes next. Physical exam, well, it depends on the chief complaint of the patient. Mostly if I'm doing an admission, I'm doing a generalized physical exam because I don't want to miss anything, right? So I will do like general, acute distress, alert and oriented ×4, then you do cardiovascular exam, respiratory exam, abdomen exam. Those are my 3 main ones that I always do. And then depending on whatever the patient is complaining of, I will do neuro exams, MSK exam, extremities. Well, the extremities, you always look at the extremities. You say if you notice any edema, any rashes, anything like that, okay? Sometimes it's really important to do HEENT. That's head, ears, eyes, neck, and throat, okay? Really important to look in the throat, especially if they're complaining of something that looks infectious or thyroid related issues. It's really important to touch the thyroid, check if it's swollen, okay? So that is the physical exam. Then labs. What have been the labs that have been done? Whatever you didn't present in the ED course and whatever has been done after that, say it. Imaging, whatever you didn't say in the ED course or in the one-liner, say it. And then micro, sometimes we're pending blood cultures, urine cultures, you say those are pending, okay? Assessment and plan. Okay, so those, I'm gonna make a different video explaining exactly how I approach my assessment and plan, because that is the most important part of doctoring, right? As a third year medical student, you need to get good at these presentations, but then as a fourth year, you're working towards a better assessment and plan. But you always need to try to make something, a hypothesis, right? Your assessment includes all your problems. You make a problem list, and sometimes you can put the problems together into one, like kind of like group problems. And then for each problem, you will have an explanation of what you think it is, right? That's the assessment part, based on everything that we have presented before. That like the clinical pictures is most likely suggesting this and this and this because this and this and this. And then the plan. Each problem has an assessment and each problem has a plan. And the plan is kind of written in a dot form after the assessment. But you present all of those to the attending as well. So yeah, I know this has been really long, but I hope that it's kind of like giving you an idea of my thought process, how I'm going through this. Now I'm going to move towards the progress notes. These are the ones that you're gonna be doing the most often. So stay with me. Let's go over how the progress notes is different. Progress notes are given for patients that have been admitted yesterday or the day prior, you know, how, like every day, on an everyday basis. It's not the initial presentation of the patient. The attending already knows the patient. You're not gonna bore the attending with everything, but you do still give a one-liner. The one-liner never goes away. So that one-liner includes, like I said, name, age, sex, 3 points of medical history, 3 points of HPI that are really relevant. I say 3, but you know, whatever, depending on what the patient has, 3 to 4, you know, but limited. You're not going to include all the points of the past medical history, all the points of the HPI. No, like succinct. What's the most relevant? And lastly, 3 points of objective information, which includes physical exam findings, labs, imaging. Okay, that's your one-liner. Should always be set every day, because the doctor needs to get reminded of who's the patient we're talking about. This is what's relevant. This is what we worry about in this patient, okay? And then after with the one-liner, you give updates if we were waiting for something specifically, like an MRI or urine cultures or blood cultures that we were waiting for. If we had received those information, you don't want to wait until the objective to tell the doctor about them. If it's really relevant to the situation, like let's say the urine culture grew Pseudomonas and we're dealing with a complicated UTI that we were trying to find the specificities, you say it right away. These are the things that I didn't learn much in medical school, and I had to learn through practice. You say the important things right away. You don't want to keep the doctor or whoever's listening to you waiting there until you say all the subjective information. That beginner level, okay? So that's part of the one-liner as well. Then subjective. The subjective is different from HMPs. The subjective, you're not going to include all of the social history, family history, surgical history, all the past medical history. You don't need it, okay? Those you don't repeat on progress notes. You repeat overnight events, how did the patient feel, any information from the nurses that is new. They always try to talk to the nurses, always, if you have some time, please. They have a lot of really useful information most of the time. What happened overnight? What was done? Okay? And consults. What consults were made? Did they see them? What were their recommendations? What else did they order? Okay? Even if we don't have results, we want to know what did they order. And that's part of the subjective information as well. Okay? Then you go into objective, assessment, and plan, which I already explained. So yeah, guys, you see how I get really excited about these things, because I feel like if you follow this method, it's easier. And in the morning, the first thing you do is pre-chart. I start my note right away. The note that I'm gonna submit for the patient, the daily notes that you're supposed to submit. I started as soon as I get to the hospital because I'm looking at vitals, I'm looking at imaging, I'm already looking at objective information, and I added to the note really quick. Then when I'm presenting, I already have it in front of me. I just I go see the patient, finish seeing the patient, get into my computer, write down really quick the subjective. But the subjective information is something that you can note in a notebook, okay? You do not need to write all of these lab values, imaging results, all of that. And that's what I did wrong starting third year. I will write everything down, and it will take me forever, and it will take me more time to go see the patient, you know, because I already spent so much of my morning in the computer trying to write lab values. No, this is all in the computer. This is why we have computers that help us now, and a more efficient system. So now I don't even write lab values or imaging results, okay, or assessment and plan, because I'm working through my assessment and plan in the computer as well as I'm gathering more information. What I write, I take my little notebook when I'm going to see the patient. If it's something that I feel, you know, really relevant and that I'm not gonna remember, if I have, like, right now I'm seeing like 4 to 5 patients, so I kind of write a little bit so that I remind myself anything of the subjective, anything that the patient tells me, and the physical exam, if there were any relevant. I just write plus hepatomegaly, or like plus mother tenderness to palpation in the epigastric area, you know. Those are the things that I write now. I never write all of the information anymore because that's just a waste of time, right? And then when you're presenting, you have the note in front of you. If you don't do table rounds like we do, which gives us the opportunity to have the computer in front of us, you could print it, you know, print it in like 2 notes in 1 paper so that you don't waste so much paper, but print it because you don't want to be writing down all of that. That's just a waste of time, you know. You can just write it in your note in the computer, okay? Thank you so much for listening to me and spending this time with me. Let me know down below if this was helpful. I hope it was. I feel like we struggle a lot with this when we're new to the clinical you know, clinical practice, and even though it's my favorite to, you know, be able to see patients on a daily basis, this is something that we must master. Otherwise we feel incompetent and we feel, you know, nervous while presenting a patient when we shouldn't. So practice, follow this guideline, realize the difference between this type of presentations. Something that I missed that I forgot to tell you: if a new doctor comes and they have not been in the service and you're presenting a patient that they don't know, but the patient has been here for a few days, you need to give a hospital course. So you give your one-liner like I taught you, and then you give the hospital course in a succinct manner. Whatever most important things happened. What were the events that have happened that have kept them in the hospital? You know, what happened and what are we doing today? And what is our expectations of them? Like, when are they going to be able to be discharged? So yeah, thank you so much for listening. I'm gonna, like I said, I'm gonna make another video about assessment and plan in more detail, because that's, I could talk forever about that as well. But at least you know kind of an idea of how to differentiate the different presentations and what are things that are important to include in your presentation, and the order of things, which makes everything more understandable, easy to understand. So yeah, thank you so much for watching, and I'll see you in the next one.